Thank you, and I'd like to thank the entire European Association for Cardiothoracic Surgery for the privilege of presenting this material. I have no disclosures. The 2020 American Guideline recommendations for surgery have remained largely unchanged. Note that there is still only one Class 1 indication for tricuspid surgery, and this is in patients with severe TR who are undergoing concomitant left-sided surgery. At first glance, the surgical management algorithms also appear to be unchanged, but in aggregate, there are important advances. Annular dilation is now specifically defined as greater than 4 centimeters, and the pulmonary hypertension indication of the past has been broadened to include any evidence of right heart failure. The management of primary and secondary disease is now largely the same. Asymptomatic severe primary TR should be treated with surgery, and all stages of severe TR should be repaired or replaced at the time of left-sided surgery. For patients with severe TR and right heart failure, 3 management categories remain. Patients with severe symptomatic TR from primary disease should have surgery. Patients with symptomatic severe secondary TR from annular dilation and who are poorly responsive to medical therapy should have surgery as long as they don't have fixed pulmonary hypertension or advanced heart disease. And patients who have had previous left-sided surgery and do not have severe pulmonary hypertension or severe right ventricular dysfunction should also have surgery. The principal changes in the management algorithm are these extra layers of stratification in medical management. They appear to have resulted in better patient selection, lower operative risk, and improvement in symptoms following surgery. But in my opinion, the most important advancement in the guidelines is in stage definitions and quantification of TR. Note that valve anatomy and the distinction between primary and secondary disease has been eliminated, and there's new emphasis on objective hemodynamic quantification of TR. Specifically, effective regurgitant orifice, abbreviated ERO, and regurgitant volume have now been added. As you recall, there are a number of ways to quantify TR. The 2014 guidelines define severe TR largely based on jet area, vena contractile width, and hepatic flow reversal, all of which are somewhat subjective. The 2020 guidelines added measurements of flow convergence and using the Pisa radius. Although the Pisa radius is helpful, like the vena contractile width, it has its own set of problems because of the non-elliptical orifice of a regurgitant tricuspid valve. But Pisa does allow for calculation of the ERO and regurgitant volume. Currently, ERO and regurgitant volume only serve to distinguish moderate or progressive TR from severe TR, but that's changing. Following difficulties interpreting the results of the SCOUT trial, Rebecca Hahn proposed further stratification of severe TR so that it includes massive and torrential TR. This is supported by recent work by Bartko and Associates that demonstrates that when the hazard ratio for mortality is plotted as a function of vena contractile width, there is a relationship between the vena contracta and mortality. But that association plateaus and vena contractile width ceases to become a predictor of mortality once it becomes beyond 7 millimeters. However, there's a near linear relationship for both ERO and regurgitant volume that persists into the highest mortality groups. Therefore, quantifying TR using ERO and regurgitant volume allows stratification of the highest risk groups. Perry and Associates published similar results. They also plotted the hazard ratio for death as a function of ERO. The spline curves show the impact of ERO on mortality by univariate analysis, and more importantly, by multivariate analysis that was adjusted for ejection fraction, systolic pulmonary pressure, and age. They identified a statistical breakpoint of 0.7 centimeters squared, beyond which TR was considered massive. This slide summarizes the findings of Bartko, Perry, and Rebecca Hahn's recommendations. Fortuny and many others have also contributed to this work. Even our surgical colleagues have shown interest in expanding the staging system based on further stratification of severe TR. The guideline synopsis puts things nicely into perspective. Outcomes of patients with severe primary TR do poorly with medical management. Treatment of secondary TR is targeted at pulmonary hypertension and myocardial disease. Tricuspid surgery is recommended at the time of left-sided valve surgery to treat severe TR or to prevent the progression of moderate TR. Surgery should be considered for isolated TR, either primary or secondary, attributable to annular dilation, and in the absence of pulmonary hypertension or dilated cardiomyopathy. Unfortunately, interventional mortality for severe isolated TR is still high, with a reported operative mortality of 8 to 20%. But most of these interventions were performed after the patient already had end organ damage. Namely, we were too late. So there's been renewed interest in earlier surgery. This interest is because there's an increasing number of patients presenting with right-sided heart failure. We now have more advanced surgical techniques. The patient selection process is better, as I've shown. And this has resulted in lower operative risk and documented improvement in symptoms. Of course, there's growing interest in development of catheter-based therapies for TR. And finally, in my opinion, improvements of quantification of TR will lead to more clearly stratified stage-based intervention and better results. Despite all this talk about regurgitant trade, as surgeons, again, I encourage you to focus on the fire, the anatomy, not just smoke. I'd like to thank you for your attention and the opportunity to present this summary to the European Society.
Dr. Drake, thank you for this very nice presentation. Any questions from the audience? No? Okay, just a quick question. Obviously, one of the problems sometimes is the RV failure that we see in these patients. Do you have some indication in a patient that do not has pulmonary hypertension, very large TR, but a very dilated RV, and the discussion is, should we operate on him? Should we not operate on him? Is he going to come out with ECMO? So what would be your strategy on this for these patients?
The surgical group that I presented at the very end with that stratification, and I will try to bring it up. This paper is a really important paper, in my opinion. Am I allowed to go backwards on my slides?
We don't have a control of your slides here, so I don't know.
Okay. I'll keep talking while I'm trying to bring it up. But basically, there's a very nice publication. Gilles Dreyfus, Rebecca Hahn, a number of others were also on this, and they stratified right-sided disease into 5 different categories. I think that represents a state-of-the-art presentation that we probably should all have at our dispense. And again, I'll try to bring it up, but unfortunately, let's see, here we go. We're doing it. This paper is excellent, and I would strongly recommend that every cardiac surgeon who's trying to discern who should not be operated on and who are good candidates should have this at their disposal.
Okay, so we'll read it. There's a question from the floor.
Yeah, LaRusso, Maastricht, the Netherlands. Thank you for a nice presentation. But we have your comment regarding a little bit more in-depth workup, particularly for surgical patients. What do you think about the role of MRI to evaluate right ventricular myocardial, I mean, the quality of the muscle, if there is fibrosis and so forth? Because this is going to be, I guess, a major determinant for the perioperative outcome.
I completely agree with you. It's not necessary for many patients. I mean, let's face it, somebody that's got mild right ventricular dysfunction is undergoing mitral valve repair, there would be no doubt you'd fix moderate. But I think for the very sophisticated, for the very sick patient, as is shown in this slide, frankly, you can see that myocardial fibrosis on the right side can be a big predictor for adverse outcomes. So in the patient that's marginal, yes, I think MRI is an important adjunct.
Thank you.
I have a question. Very nice presentation on the new guidelines from the American side. The European side is similar in terms of the recommendations. The thing that strikes me the most is the fact that many of these different stages, the different recommendations, they always focus on cardiac pathophysiology. But we all know, and even the interventionalists addressing the tricuspid valve now realize that right heart failure after closing a valve is not happening. And it may happen, but it may not be related to the decrease in function. And if you play sort of a volume game and you take the regurgitant volume away and then you calculate what would you expect in terms of ejection fraction from the right ventricle after the valve is closed, you know, you would think completely different about this this pathophysiology. So I wonder why, you know, we all know that other factors, we'll get to this in the session even later, why don't we address the periphery? You know, in aortic valve, we know the cancer, you know, of the peripheral organ damage is the cancer of aortic valve. Similar, you know, those analogies are made for the aortic valve, but in the tricuspid valve, I think this is even much more prominent. This problem, you're right, liver dysfunction, renal dysfunction. So why don't we address these things in the guidelines a little bit more?
First of all, I completely agree with you. And I think there is now recognition of that. Like, as I said in one of the points in the synopsis, there's absolutely no question that the cardiologists are fully recognizing if they wait too long, they are getting disastrous results. So there is a push for earlier surgery. Your points are exactly correct. We really need to try to avoid waiting until there's end organ damage. It's just too late. So I completely agree with your statements.
So probably one more question in that direction. So when should we not operate a patient? What is the cutoff in your personal experience? Is it the liver function, the kidney function, or when would you send a patient for a clipping procedure or for an interventional procedure?
Oh, I wish I could be real objective. Again, if you look at Tiramiso's stage 5, he alludes to that. Basically, when you have multiple end organ dysfunction, if you have what appears to be irreversible pulmonary hypertension, once you get into that category, I think it's awfully important that those patients undergo a right heart catheterization to make sure there are no illusions. We've seen that I'm a huge proponent of echo, but we've seen that it becomes somewhat unreliable in patients with very advanced right heart disease, simply because most of those things that we're measuring, whether it be regurgitant chet or Pisa radius or whatever, are profoundly, I should say, are somewhat less reliable because of the low pressures of the right heart. And so I think in that situation, MRI, right heart catheterization, and the aggregate picture, I mean, I think this is a multidisciplinary team approach, but you're spot on. You know, as soon as you start to see serious liver failure, then you know that your mortality is going to be in the 20+% range, especially if there's a significant coagulopathy. So all of your points are superb, and it has to be weighed by the entire team.
So there's actually one question here from the chat, and El Nazir Abdallah asks, thank you, CTEF surgeons. Do not address severe TR. Comment, please. You know, the pulmonary endarterectomy, if that's operated, obviously, he says that there's no tricuspid regurgitation addressed in these contexts. Can you comment on this?
Gosh, no, I can't. I can't imagine not dealing with the TR at the time of that. You know, once again, if you're in for a very quick procedure and you think there's going to be complete ventricular recovery, I suppose it's reasonable. But if the patient has severe TR, it seems to me that that should be addressed concomitantly. I mean, I think the guidelines are very clear. We should not be leaving people with severe TR, isolated TR. We should not be doing that.
Okay, thank you very much.